We often hear from members of the community about the difficulties around accessing healthcare and treatment for DPDR symptoms. So we've worked with leading expert psychologists Dr. Elaine and Dr. Černis to create this resource to help clinicians identify symptoms and support those living with the condition. What are some of the most common ways people describe the experience of DPDR?
So, lots of people with depersonalisation, derealisation say it's really difficult to describe their experiences. So you need to be quite astute as a clinician to be able to kind of pick that up, because they might actually be struggling to put this experience into words. So they might talk about things not quite seeming right, things seem a bit off. They might talk about things, things look a bit sort of fuzzy, or that feels like there's something between them and the outside world, like glass, or like they're in a bubble, or there's a veil between them and the outside world. Or they might talk about just feeling quite disconnected from their own experience. They might talk about feeling really numbed from different emotions. So it's really being able to kind of hear those things and actually be able to be aware of the different symptoms that can constitute depersonalisation and derealisation, so that you're able to kind of, rather than misdiagnose it as something else, or kind of think, I'm not quite sure what that is, but I do know that they've got that, but actually to be able to kind of think, oh, maybe this is what this is. And then there are particular questions that you can ask that will help to clinically diagnose that. So asking them quite explicitly about depersonalisation, times where they felt cut off or detached or unreal about themselves or the outside world, and putting that into a little bit of some language that people may be able to kind of feel like resonates to them. Because lots of people with depersonalisation, derealisation say that when somebody uses that word or terminology, they kind of go, oh, okay, that's what it is. I wasn't quite sure how to express it. But I think it's useful for clinicians to also be aware that people are often very frightened about what these symptoms might indicate or mean. And they're maybe very reluctant to kind of talk to you about it. They might sort of say it, sometimes called a sort of door handle moment. They're just about to leave and say, oh, by the way, I've also experiencing this. And so it's good to just really try and help them to elaborate and express what they're feeling, because they are classically very difficult to put into words.
So some of the common things that I might hear is a lot of as if statements. So it feels as if, or it's like. So people trying to use really rich descriptions and analogies to try and get across the feeling of what it is. But ultimately people have been describing to me feelings that are strange or odd, or that they somehow can't quite get into words. So there's this feeling of anomaly, of weirdness that people just can't quite place. And that, of course, is very difficult to describe. So picking up on things that have that flavour, but also where people are trying really hard and using lots of different descriptions and analogies to try and get across to you what it is that they're feeling, that can be a clue that there isn't quite the right word or quite, the right vocabulary there to explain it. So that is a big clue for me that we might be talking about dissociation or depersonalisation.
Once DPDR has been identified, what are the first steps that can be taken?
So if someone's presenting with those sorts of symptoms, I think the first thing you'd want to do is kind of find out what may have triggered that for them and how long those symptoms have been around for them. It may be that they've quite recently experienced this and the symptoms are quite new, and that they may just naturally recover. So one of the most helpful things to do is to put a name to it, and to also reassure the person that this is a condition, and that they may actually recover naturally, because I would say most people with these experiences, given some reassurance and a bit of help and support, understanding what may have triggered that off, they may be going through just an extremely stressful period of time, and these symptoms are temporary, and that they will naturally resolve themselves. So this might be what we call sort of watchful waiting. So you might suggest that, see how they go, and it suggests that they come back to you maybe in a few weeks or a month if those symptoms haven't resolved, and then you can start to think, well, what else do I need to do now?
I think the first steps really are what we would call psychoeducation, so giving people information. A lot of the time people who are experiencing depersonalisation for the first time are really concerned about what this is because it feels so odd, and it can be pervasive, and anything that sort of affects how you feel about yourself or the people around you rightly is very distressing. So I think some information about actually this is extremely common, some information about how this is also a normal way that your brain and your body behave, that can be really reassuring. Also that the person isn't going mad, that they're not alone, that other people experience this too. All of that can be really reassuring, and then help you kind of get down to the bottom of why is this being triggered for you, or what is it that's keeping this stuck. So then you can start to understand, why has this become a problem? The depersonalisation itself isn't a sign that something's wrong, but I guess the fact that it's persisting, or the fact that the person is distressed by it, might be the thing to then work on with them. So asking more questions, trying to give a bit more information, trying to reassure that this isn't something that's necessarily going wrong, but that you're really curious and you want to help them understand how to bring it under their control again.
And if the symptoms don't resolve on their own, what should happen next?
Yeah, so the next step, if that's not naturally resolving, might be to look at either, depending on what the client would like, either to get some support through maybe some talking therapies. So you might be able to refer, or the person can actually self-refer in a lot of cases, to talking therapies. But you would want to help that person by actually having a diagnosis to go with it. So it would be useful for that person, either if you're referring them, to make that clear that they're experiencing depersonalisation, derealisation, so they don't have assessment problems when they get to the next stage, or for that person to take that diagnosis with them. So that's one option, because I think in a lot of talking therapy services there will be people that have got access to information about how to work with that person. And we know that actually from a recent randomised control trial, that actually even people in the treatment as usual group did benefit from the CBT, even if it was general CBT. So it might be helping their anxiety, it might be helping their depression, and as a result helping their depersonalisation, derealisation. So that's a very helpful route to send people along to. You may also want to think about, if you're a GP or somebody that can prescribe, you may also want to discuss with the client whether they might want to have a short-term course of perhaps an antidepressant that might again also help their symptoms, but via helping reduce their stress, helping reduce their anxiety and their depression, because there's no explicit medication for depersonalisation, derealisation itself.
Can DPDR be present with other conditions?
Absolutely. So it's very common for people with depersonalisation, derealisation disorder to have either other types of anxiety, or to have anxiety about these symptoms, and maybe some low mood, either again independently or as a result of their depersonalisation, derealisation symptoms. So what you can also think about doing is helping that person with what may have led to the development of the depersonalisation, derealisation disorder. So that might be treating the anxiety that hasn't been treated, or their low mood. So that can be helpful. So we would suggest that you would want to treat any what would be called sort of Axis 1 disorders. So anxiety, depression, those kind of problems. You might also have other associated things. If it's caused by trauma, for example, you might want to refer to trauma services and treat either the PTSD, or if there's more complex PTSD, childhood traumas, you might want to treat that and see again, does that resolve the depersonalisation, derealisation symptoms? And if those other conditions have been treated and the person still has depersonalisation, derealisation disorder, you may then want to think about referring to a specialist service.
Are there any specialist or tertiary services available for the condition?
At the moment, there's only one NHS specialist service that's based at the Maudsley Hospital in London. That's been going many, many years and has good outcomes. In fact, two clinical audits from that service actually have shown very positive outcomes and actually allowed us to get funding to see whether we could roll that out across the NHS, but that's still a research process that's happening at the moment. But you can make referrals to the Maudsley service.
What resources are available for mental health care professionals?
I think it can be really helpful to use a questionnaire or a scale in a session, not just for measuring the severity of a problem or tracking progress, although those are great things too, but also to get across that there are ways of putting this into words, or that the person isn't alone, because there's a whole questionnaire which has been developed with thousands of people and is used by thousands of people, so that they're not alone, and it's very clear from that moment of using that questionnaire that that's the case. Good questionnaires to use. I quite like the Cambridge Depersonalisation Scale. I've developed one of my own, which is the Černis Felt Sense of Anomaly scale. That's quite good for experiences that are very difficult to put into words, where the main feeling is something strange is happening. There are plenty of others. You might come across the Dissociative Experiences Scale, or the DES, which is one that's been used for many years now. If you wanted to do a diagnostic interview to understand whether somebody's meeting criteria for a particular disorder or diagnosis, a diagnostic category, you'd probably be best doing a diagnostic interview like the SCID-D, which you would need some specific training around. You could pick up the interview manual and see the kinds of questions in there that might help you kind of ask curious questions with your clients, with your patients. But I would recommend the training to get that really well done assessment.
So if you're a GP, I suggest that you might go and have a look at an article that we wrote for the British Medical Journal, and that really talks about what you can do if people are presenting in your GP surgery with depersonalisation, derealisation disorder, from just watchful waiting to referral for Access 1 or more complex problems, secondary care problems, or for specialist depersonalisation, derealisation services. But there's also an interesting interview of where the authors are being interviewed, and also the editor of the British Medical Journal at that point as well joined and talked about her own experiences with depersonalisation, derealisation disorder. If you're a clinician and wanting to use CBT, I would recommend that you have a look at the Overcoming Depersonalisation and Feelings of Unreality book. There's a second edition on that, and that will give you some indication of the key areas to cover in CBT. And if you're a psychiatrist, there is an online module that you can do that's on the Royal College of Psychiatry website, and again there's a podcast that we did in association with that as well.
And finally, do you have any other tips or advice for practitioners?
The most important thing is to not panic. This isn't something that you can't deal with. The main thing you have to do is listen, and really listen. So it is very, very, very difficult to put depersonalisation and dissociative experiences into words. So you're going to have to do a bit of extra work, really hearing what the person is trying to describe to you. And these things might sound a bit similar to depression, especially if somebody's talking about feeling numb. So be curious and ask more questions. If you're not really sure what exactly people are experiencing, it might be a clue that it's depersonalisation, but it might also mean that it's time to ask a few more questions and really try and understand what it's like for the person. I think the main thing that I'd want to say to clinicians is what I said earlier about really listening and really asking questions. And I think kind of parking some of the expectations of what people might be saying and just being open to hearing something else. And we can only really hear that if we're really, really listening. So I think there is something there about understanding that somebody might be trying to describe something to you that is very difficult to put into words. And the reason that I say listening is the most important thing isn't just because I'm a psychologist, but I've done clinical interviews and I've done research interviews with people where unfortunately they've described that they have tried to explain these feelings to people and been so misunderstood that they've not tried again. And that to me seems like a real shame, and it guarantees that that person won't get the support that they need. So it's on us really to give that opportunity for us to understand what it is somebody's trying to explain.